Hey guys, Scott here, the Gait Geeks, and today we're going to be talking all about Hallux Rigidus and Hallux Limitus, so stay tuned. Hey guys, welcome back to another episode. I am Scott, and as always, I am joined by Ivo. Ivo, how are you today?
We are good. I am really excited about talking about Hallux Limitus. This is going to be a lot of fun. One of my favorite things because we see it a lot.
Yeah, it's one of those things that I think gets underappreciated. The importance of that big toe, right, and how well it moves or doesn't move is something that I think many clinicians tend to bypass its importance. But I really find that it really helps dictate how the foot moves and functions.
Well, it really does. And if we don't have good dorsiflexion in the first MTP, we don't have good high gear push off. And if we don't have that, then we have inefficient gait. So super important. And an interesting thing I learned from reading the article that we're going to talk about today is that, here it is. Acta Biomedica. This is actually an Italian journal established back in 1885, if you can believe that. Thought that was kind of cool. Anyway, 2.5% of people, it doesn't sound like a lot, over age 50 have some degree of Hallux Limitus or Hallux Valgus. Not Valgus, I'm sorry, Hallux Rigidus. Mm-hmm. Yeah, which I was just kind of like, wow, that's a lot of people. And it's probably a little bit more than that as far as that we're seeing. These are just the cases, that they looked at in this particular review. That we were looking at. So Scott, why don't you talk real quick about what is Hallux Rigidus, what is Hallux Rigidus, right? I'm going to say Hallux Valgus because I had this guy with the most enormous bunions in about an hour ago. They were huge. I should just take a picture just to post.
Yeah, you should have.
They were enormous bunions, and that's all I've been thinking about. But talk a little bit about what the two of them are, and then I'd like to talk just a little bit about first ray axis of motion, and we can get into the article a little bit.
Yeah, I think the biggest thing to understand and appreciate is there are varying degrees and there are various causes, right? So when you're talking about a limitus, a Hallux Limitus, it's obviously less restricted than a Hallux Rigidus. So a Hallux Rigidus usually involves more bony arthritic changes to the joint in which that hallux dorsiflexion is extremely limited if takes place at all, right? Whereas a limitus situation, there is still some mobility in that joint, and any of the restrictions tend to be more soft tissue related. That's how I kind of judge the differences.
Yeah, and with rigidus, once it's there, it's kind of toast. I have never seen a rigidus get better. I have never seen a rigidus. That was a true rigidus. When you do an X-ray or you do an ultrasound of there, you're going to see a decrease in joint space. A lot of times you're going to see osteophytes. The motion is just there. Or sometimes people have had that fused because they did have a bunion surgery where they did a wedge osteotomy or something like that, and that went south and they were having pain. So they just fused the joint. Limitus, a lot of times you can get more range of motion out of it. So normally we're looking for
tissue related because it's more soft tissue. If you have bony changes, you really can't undo the hands of time, right? Soft tissue is a little bit more pliable.
Right. Although when you have bony changes, sometimes if you can change the axis of rotation of the joint through soft tissue manipulation and stuff, you can actually gain a few degrees of dorsiflexion of that big toe. Normally, we want to have 65 degrees, right? That's what's ideal. You need about 50. When you start getting below 50, that's when we start to have a problem. We're talking about dorsiflexion of the hallux here. So I've got my trusty old model here, Maggie May. We're talking about this motion coming back right here. And we need about 50 degrees to be able to walk normally. So, we have the terminal phase of gait. So we have terminal stance and pre-swing where we're getting dorsiflexion or forefoot rocker that's occurring in that area. What happens with Hallux Limitus is somehow the axis of rotation of this metatarsal bone has moved dorsally and posteriorly. When that happens, it limits how far we can dorsiflex the big toe backwards. So what puts down the distal end of that first toe? Scott, why don't you talk about a couple of things that actually create this down? Because the further down this is, theoretically, the more dorsiflexion we can do. So when you're examining that patient's toe, one thing you should be doing is plantar flexing the distal aspect of that first to see how much dorsiflexion is potentially even available for this person.
Yeah, I think
before we
prona's
start giving a
longus,
bunch of exercise.
prona's longus is one of the first things that jumps to my head as probably the most
Absolutely.
important thing that really depresses that first ray.
Yeah, so we know that proneus is going to come down the outside of the leg, come
Mhm.
around the lateral aspect, hook around the peroneal tubercle, and it comes and attaches right to the base of the first here. And that's an actual, it raises the base of the first, which drops the head of the
Correct.
first. Yeah.
Correct.
We talk about orthotic therapy. We also talk about, instead of pressure here under the navicular, we want the pressure back here under the substentaculum tali. Because if we can support them there, we pick this up, and if we pick up the proximal end, and they even talk about it in the article, which I was very impressed, that drops the distal end. There's a couple other muscles, though, that can also help to drop this down. The extensor hallucis brevis, okay, which is a slip of the extensor digitorum brevis that comes across the top, attaches to the dorsal aspect here. So when that's fired, okay, and remember that just goes to the proximal phalanx, that helps to sink it. And then, believe it or not, the short flexors of the rest of the toes in this area here move the heads of those toes dorsally and posteriorly, which effectively plantar flexes the first.
Mm-hmm.
Those three things are super important for doing that. And if we don't have that motion, then we don't have a whole lot of options, right? We can fuse the toe, or we have some orthotic interventions that we'll talk about as we start to get down.
It's also important to assess the range of motion, at least in my eyes, in both a non-weight bearing position as well as a weight bearing position. So, in my opinion, if you assess it in non-weight bearing first and you don't have that mobility, you're up the creek without a paddle. At least I have never seen somebody have limited motion in non-weight bearing and all of a sudden put their foot on the ground and all of a sudden have tremendously more motion into that extension range. I don't know.
Absolutely.
Yeah.
But you see the opposite all the time.
Correct.
Where people have a
good amount of range.
They have a decent range, but when you put the foot on the ground, they have very limited motion.
Correct.
And that's interesting, or that happens a lot of times, again, because the distal end of that first moves dorsally and posteriorly, limiting the amount of dorsiflexion. And they talk about that in the article as far as that. Can you bring up that one picture, Scott, of the dorsiflexed foot? Here we go, right here. So when we're at terminal stance pre-swing, which is exactly what this slide is showing right here, you can see that the hallux is supposed to plantar flex an additional 10 to 15 degrees compared to the other metatarsals in that area. And that allows for that head to move anteriorly and inferiorly, which allows dorsiflexion to occur. One of the pathological things that we see, you can pull that back down now, which can happen is the plantar fascia creates the windlass mechanism. Remember what that's talking about, right, guys? So we've got the plantar fascia underneath the foot. Sorry, get my foot around right here. The plantar fascia underneath the foot here. So as I dorsiflex here, that pulls on the plantar fascia, which helps to bring the arch effectively up. If I have plantar fascial dysfunction and pronatory problems with the foot, that's going to bring the base of that first down, which effectively raises the head of the first, and that's going to limit that dorsiflexion. And that's that soft tissue thing that Scott was talking about just a minute ago. Along with that, of course, we have the plantar plate of that first met, which is interesting. It extends almost 2 millimeters proximally, but less than half a millimeter going anteriorly, where it's going to attach. But that's going to help stabilize that MTP joint in that area as well. So if that plantar plate has been compromised because they have a small tear or something like that, that's going to compromise the mobility of that joint and allow hypermobility. In that particular case, we definitely need to unload that while it's healing up.
Yep. Why don't you talk a little bit also, Ivo, about like that dorsal exostosis that sometimes occurs as a result, and really thus limits some of that extension as well.
Yeah, so here's that picture there, and we see that a lot of times, that little osteophytic crown that you can feel and palpate with your foot at the MTP there. Again, if you can imagine that distal end of that first metatarsal moving posteriorly, and then when I try to dorsiflex that toe, it just bangs into the cortex of the bone. And if we do that over a long enough period of time, the body says, oh, we're getting a lot of stress in this area. Let's start depositing bone there. And we start to get that osteophyte in there. So sometimes they'll go through and they'll do a cheilectomy where they go in and they actually shave those osteophytes off. And sometimes that'll work and allow the person to have more dorsiflexion. Sometimes it doesn't. The rehab, if you're going to have that done, is extremely important to get mobility back in that pretty much immediately post-surgically, because otherwise the soft tissues are going to tighten up in that area, and you are not going to have the dorsiflexion that we need.
Talk about it in your opinion, how, because I'm kind of dealing with this kind of now, where I've had a patient that's had that exostosis surgically debrided and has since started developing more of a sesamoid type of problem. Can you see a world in which those two type of diagnoses are linked?
Absolutely. One, because of you're changing the axis. When we've had that, cheilectomy done, we're changing the axis of that joint, and we've eliminated some of the posterior stability that's occurring in that joint, along with the plantar plate on the surface. And we already talked about plantar fascial dysfunction, which is going to occur. So if we get shortening or lengthening, I imagine, of the plantar fascia in that region, we have midfoot pronatory issues occurring in there. Not only are we going to limit the dorsiflexion because we're moving that joint dorsally and posteriorly, but we're also taking the hallux and we're rotating it on the long axis this way. So we're rotating it on this axis here. And if we rotate it on that axis, it's going to limit its motion there. What that does is it takes muscles like the abductor hallucis a lot of times, and it's going to shift its axis of rotation, which most of the time is already on the plantar surface. It moves it even further plantar, which creates more of a hallux valgus situation. And if we take that joint in this area here, okay, this MTP, and we put that into valgus, that's also going to limit the amount of motion. It also depends upon the shape of the articulation in this area here, whether it's a planar articulation or this little one that looks like a mountain peak, as far as the morphology of the condyle of that distal net.
Yep. So in terms of treatment, if somebody has a more, like we talked about, a hallux limitus, we're going to be more likely to be successful or have success with our treatment strategies, whether it be joint mobilization, soft tissue mobilization, or in the case of improving the we'll call it the alignment of the midfoot into the forefoot with strengthening, right, to make sure the proximal end is more dorsal, to drop the distal end down. Obviously we talked about whether it be the short flexor strengthening or whether it be the proteus longus, keeping that first MTP down, those type of things. What are some of the go-tos that you like to utilize for your treatment strategies in this situation, and how successful have you been?
I would say 50-50 as far as success. I'm not sure if you're there as well. It depends. Once there's been osteoarthritic change, we x-ray a lot of people, and we also do ultrasound on a lot of people. If there's a lot of tissue changes and we're seeing granulation tissue and stuff like that that's already forming, it's a lot more difficult because the cases are a lot more recalcitrant as far as improving that. We're great at getting down the inflammation and stuff, but it's not always great at restoring the motion. However, I'm sure you're going to talk about this in just a second here. We've had pretty good luck putting people in a rockered shoe, as well as utilizing a orthotic or a carbon plate or something like that underneath, sort of like a Morton's toe extension, which is going to limit the dorsiflexion of that joint. Why don't you talk about that a little more? And I think we got a couple of slides on that, Scott.
Yeah. So here's the Morton's extension, right? And what that Morton's extension does is it tries to further limit or prohibit that extension to occur, because when in a lot of cases when it tries to occur, it's painful. It's not the best situation. So by extending this carbon plate, that's what this is. It's a carbon plate that extends down the medial aspect by the first to really limit the amount of extension or dorsiflexion that occurs in that first MTP. I tend not to love these, to be honest with you, in a lot of my population. I really go to it as a last resort, just because I really firmly believe of the importance of trying to get that extension back. And if somebody is walking around with that all day long versus somebody that is just wearing a plate like that during a given activity, I think those are the different situations where I like, so if somebody is an athlete, let's say, and they wear it during a given activity, I'm okay with that, but also not okay with it. And I'll explain what I mean by that in just a second. But I'm okay with it in the sense that if it decreases their pain and it allows them to perform, that's one thing. And then they're going to come out of it and hopefully not further restrict that joint and try to work on trying to get as much movement as they quote unquote can back. That would be great. The problem I have with it is when you limit first MTP extension or dorsiflexion, you're really changing the mechanics of any type of athlete. When we talk about, turf toe, which is in essence a similar situation of this, that ruins careers. Being able to pivot and push and to cut off of your first and of your medial aspect of your first and kind of, really get that extension to change directions in a forceful manner is critical of so many sports. And by putting a steel plate in there, you're really changing how that mechanics is going to occur and oftentimes really limiting how successful that athlete's going to be on that. So I try not to do that if at all possible. Certain sports may allow for a rocker bottom more so than others, depending on the shoe situations, cleats versus not cleats, court shoe versus a track shoe or a running shoe. So that may be an option for you. It may not be an option for you. An orthotic with a little bit of a rocker may also work a little bit. You might be able to have some more success where the bottom of the shoe is flat, but you have a little bit of a rocker inside the orthotic to create a little bit of that same type of help with or assistance with plantar flexion potentially. So those are just some things you can try. Again, not a whole lot of success in terms of changing a rigidus type of mechanic. So sometimes you got to break out all your tools in your toolbox to see what that given athlete or that person with their activity level is going to need and what is going to make them successful.
Yeah, I like that. And I think you think the same. You think of it as a continuum. You have dysfunction, turf toe, limitus, rigidus, and that's
Yep.
sort of the continuum that it's going
Correct.
along with there.
Correct.
I would have to say out of all of those things, for the reasons that you just talked about, I use rocker bottom shoes a lot. Now, I'm going to caution people, though, when you're using a rocker bottom shoe, you have to look at where is the toe break and where's the rocker occurring. If you have a hallux limitus, we want that rocker to occur right under that MTP. If you move it dorsal to that, as they're going through, you're going to stress the joint. If you have it ventral to that, it's going to stress the joint. It has to be right over the joint. So sometimes what that means is putting the person's foot inside of that shoe or having them, go to Zappos online and order a whole bunch of different rocker bottom shoes, and you find out which one's going to fit them the best. Or having them, or more often than not, what we've done in the office is we just Frankenstein the shoe. We just take the shoe and we create the rocker with a grinder right exactly where it needs to be. And sometimes that means grinding off a little bit of tread here and there, grinding a little bit into the outsole of the shoe to create that rocker for the person. But it has to be relatively rigid. If it's not rigid, like if you look at, and I'm not picking on brands here, but if you take an Ultra Olympus and you convert it and you compare it to a Hoka, the Hoka is way more rigid in the forefoot than the Olympus is. Okay, so the Hoka in that particular case, even though I'm not wild about a 5 millimeter rise in the heel, is going to be a better rocker situation because the shoe is more torsionally rigid. The Topo Spectre is another one which is pretty beefy as far as the rocker goes in that area. So you have to be super careful. And a lot of times people are like, oh, well, I don't have a rocker sneaker. How about a hiking boot? A lot of hiking boots, as long as they have a relatively rigid last, will work. And one of the other things they talked about in the article too also was a more rigid lasted shoe or changing the last of the shoe to make it more rigid. You could easily take a carbon fiber plate insert, like an outsole or an insole insert, sock liner insert, that's the shape of that, and beef that shoe up and not allow it to dorsiflex at that toe break. I think we got a slide here, Scott, of the toe break, which might help.
Here is, let me just change this real quick.
Yeah.
Hold on one second. It's asking me I don't want to be signed up, so let me close that. And let's go to this. So here's that topo you were talking about, right?
Yep.
With the rocker.
Yep.
So I wanted to bring that up just to give an idea of what we're talking about and how that kind of really facilitates more of that move to get off for a better push off.
Yeah, and with this particular topo, I believe this one has a 5 mil drop from heel to toe. It's not a zero drop, but it's fairly decent.
Yeah. All right. So you wanted to see something else. Which one did you want to see?
Just the toe brake slide.
The toe brake slide. This one?
Yeah, so the top situation here is kind of like, that toe brake where the shoe bends should be at that first MTP on any shoe. And you can actually create inflammation, turf toe, limitus by wearing the shoe that doesn't have the toe brake in the correct place over a long period of time.
Mm-hmm.
Once that joint becomes more and more rigid, they're going to be coming more and more off of the lateral aspect of the foot, like you're seeing in that bottom slide there. Okay,
Mm-hmm.
now it's a little deceiving because they're showing a right foot in one and a left foot in the other. But
That's weird that they did that.
yeah,
But yeah.
when I looked at it at first, I'm like, but the foot's in valgus. Why is that? No, it's actually
Uh-huh.
in varus. They're just showing the opposite foot. But
Uh-huh.
they'll start to come off the lateral aspect, and you can see some of the markings just anterior to the vamp of the shoe,
Mm-hmm.
which are going to be a little bit more lateral there. And you'll watch these people as they're walking. They're going to avoid getting dorsiflexion into that joint. So how do they do that? Do they toe off like this? Do they lean to the side and drag, their leg through the gait cycle? Are they prematurely heel rising and bringing that foot up in a flexion fashion? So what is their, just like with a short leg, what is their compensation pattern for getting around what's going on? A lot of people don't even realize they have that going on until you
Mm-hmm.
point it out to them. And you take a video and you show them, well, dude, this is you walking. It's like, this is what you look like. And look at the toe on this side. It doesn't move. All right. Here, this is what we need to, this is what we kind of need to do.
I think one of the biggest triggers or pieces of evidence that people are walking very differently is getting your hands on that first MTP and looking at their hallux extension, and when you see an asymmetrical extension, there's a good chance they're not walking very similarly right to left. There's a good chance that there's some compensatory action occurring on the side that's got the more restricted motion that could be dealing with or causing some of the discomfort they're having either on that side or potentially on the side even with better mobility, right? As it relates up the chain due to the compensation. So I think that's an important part of your evaluation that you need to assess with anybody that comes in that walks on 2 feet, right? Anybody that walks on 2 feet, you should be assessing when they come in with an injury, how much extension they have, because whether they have knee pain, hip pain, back pain, if they're not getting off their foot correctly, at terminal stance right before pre-swing, right before push-off rather, there's a good chance that that could be a component of what's going on.
Right. So unless you have a large Uniter population in your practice, yeah, important to look at that. And I think, Scott, maybe you remember, we just did a seminar a couple of weeks ago. This is October 25th that we're recording this one today. We have some great footage of the exam looking exactly at what we're talking about, and we actually moved people's first ray distal aspects forward and backwards and showed how the axis of the joint can change. So that
Yes.
in the next coming probably month or two here, we'll have some of that footage available over on our Vimeo channel for people to be able to check out as well.
Mm-hmm. Yep.
Yeah.
Cool. In terms of your hands, how much of the time do you use a carbon plate?
Very minimal.
Mm-hmm.
Probably, yeah, less than 2%.
It's my last go-to. It's my last go-to.
Well, we've used it, but it's just not something that we do commonly. Rockert shoe, I would say, is probably, along with exercise and stuff,
Mm-hmm.
is our go-to for a lot of these people, especially if they have a rigidus. And now, going along with that, the other thing that we'll do is we gait retrain them. So we just teach them to run differently. That's all. It's like the guy that came in to see me that had a triple arthrodesis in his ankle and he wanted to run a marathon. It's like, all right, well, we can do this. You're just going to look not like the other kids, as long as you're okay with that. And you just, you can retrain somebody to work around that. You can give them into more of a steppage gait and things like that. It doesn't mean that they're not going to have maybe other issues associated with how you're gait retraining them, but they're also avoiding surgery and stuff like that. And some people are, they don't want surgery under any circumstance for whatever reason. So there's different ways that you can work around it, just like, with any kind of a disability. It's like, all right, well, we're not going to be able to make this better, so let's help you to compensate better.
Right. I'm trying to pull up a picture right now of one of the tools I like to use. You're talking about gait retraining, give me a second here while I try to pull this up. It's one of my go-tos with regards to exercises that will assist. Let me see if I can find this slide really quick. Here it'll be in here. Give me 1 second. And while I'm doing that, Ivo, why don't you talk about this slide here and what you wanted me to bring this up here for?
Sure. So this is just other methods for raising the base of the first and dropping the head of the first. This is showing putting a scaphoid pad in. So basically a full arch contact orthotic with pressure underneath the sustentaculum tali, okay, which is going to help control the rear foot, is going to raise that base of the first and help to drop the head of the first. We want a nice steep angle, angling down on the distal aspect of that scaphoid pad as well. If you don't have scaphoid pads, you can take a metatarsal pad, cut it in half, and use the side. We use asymmetrical pads here, you can use the side that's got the larger amount of drop in there. But it works really well. You can also, if you have EVA of any thickness, we use 10 mil a lot of times when we're going to build a scaphoid pad, but you could easily bond 2 pieces of 5 together. Just basically take a pedograph, mark out where the arch is, and you can skive your own pad too. It does take a little bit of time to do that. They do have pre-made ones, which are probably good for 90% of the population. So unless you're in a pinch and you don't have that, that's a good thing to do.
Yeah, I agree. So here's the picture I wanted to bring up. We're talking about gait retraining and teaching somebody how to get off their toe and getting good hallux extension. Again, you've got to make sure that you have ample range of motion to even begin this type of movement. But whether you're doing it on the floor or whether you're doing it with some type of rocking aid to try to really accentuate and try to, now that let's say you did some soft tissue or joint mobilizations and you want to make sure somebody's functionally moving through that range, a good exercise or a good tool is something like this, where you can actually use almost like a teeter board to help facilitate them getting the correct motion over the right plane or in the right plane of mobility or motion of that first MTP. So just something I wanted to share, something I really like to use. I find it pretty helpful. I don't know if Ivo has any thoughts on that.
We do something similar, but this is for the person that does have some range and we're just trying to expand it.
Correct.
We can use either a broomstick or a paperback novel and put that just under the great toe in that area, and then have them basically go through that same motion that you were just showing at terminal stance, where we're getting that hallux dorsiflexion, and that just pushes them just a little bit further. Tom Michaud has got a great device called the Toe Pro, which is a exerciser for the distal flexors. That's another great tool to be able to do the same thing with.
It's a softer, cushiony pad to push into as well. So I have
it's a pretty dense foam, but
yeah, exactly. Yeah. All right, so take home message in summary, right? What would I'd say? Obviously, we talked about turf toe, hallux limitus, hallux rigidus. We're talking about soft tissue involvement to more bony involvement as it progresses. We're talking about treatment options being, trying to obviously gain as much mobility via mobilization, soft tissue, making sure that the strength of the appropriate muscles are functioning. Like we said, the pronator longus, the short toe flexors are doing what they need to help, depress that first at the distal end and raise it more proximally. To improve the alignment of the first MTP to allow for that extension to occur in the correct plane with your right joint arthrokinematics. Can be a very, very debilitating thing. Success, hit or miss, depending on, again, how severe it is and what activities they want to get back to. Getting them in the right shoes are helpful. A stiffer shoe can be more helpful in kind of protecting it, I'd say, early on, because again, if it's a very flimsy toe box and you don't have a lot of motion available through that joint, that's a very painful type of situation. Anything else I missed there in that quick little summary?
Nothing that you missed, but 2 big take-home points I think also are, number 1, examine them on and off weight bearing.
Yep.
Super duper important as far as being able to look at that. And number 2, don't neglect the plantar plate and the plantar fascia. That's something that I personally have overlooked in the past, and it's something that you really need to pay attention to, because it's the tissue tension interplay sometimes that's going to contribute to the beginning signs of that dysfunction, leading to turf toe, leading to hallux limitus. And sometimes it's something super simple. It's like, holy crap, I didn't realize that some of that pain they were having wasn't coming from their sesamoid. They tore their plantar plate there. And we need to address that and create stability at that MTP.
Mm-hmm. Awesome. Awesome. Well, guys, if you wanted more information about what we do and some of the content we're putting out there, head over to our Instagram page, The Gait Geeks, or over to www.thegategeeks.com, our YouTube channel, also The Gait Geeks, where we have a lot of information. This will be posted obviously on those sites as well. So if you have questions, by all means, message us, reach out to us. We'll have some online content coming soon, a full course. Similar to what Ivo mentioned before, we'll have some more live seminars coming up too, where we really get our hands dirty and your hands dirty with some of the lab work of making an orthotic and modifying orthotics. And, we'll use grinders and glues and heat and all that fun stuff. So if you're interested in learning more about how orthotic therapy could be a part of your practice, by all means, stay tuned for that stuff as well.
Take care, guys.